So hello everyone. Let's take the next question then. Okay. So our next question is identify the fistula in the diagram based on the Park's classification. So there has been the options are given in here is the intersphincteric, suprasphincteric, extrasphincteric and the transsphincteric. Okay. And there is a image is also given. So they basically gives you some image and from that image you have to answer that what is the type of this fistula has been shown here, okay, according to the Parts classification. So before going to the answer, let's try to understand a few things regarding the perianal fistula or the fistula in ano. Okay, so what is your fistula in ano in that case? So your fistula in ano is basically there is a chronic situation or the chronic condition where there is a formation of abnormal communication. Now this abnormal communication eventually forms between perianal skin in one side and the rectal lumen in the another side. Most of the cases, your perianal fistula or the fistula in ano basically develops as a result of perianal sepsis, or the patient often gives you a history of there is a perianal abscess or the history of perianal abscess has been there, and following that the patient basically started to develop such problem. Now the patient here they typically comes with a features of intermittent pus discharge. Okay, now how this pus discharge basically becomes a symptom in this case. So while having constipation, which is basically seems to be the one of the predominant uh, etiological factor while developing perianal sepsis and the perianal fistula, so there is a like few amount of the stool that basically goes into that abnormal tract. So as a result of that, there is a superimposed infection and there is a formation of the pus. Okay, and that pus often discharge intermittently, and the patient comes to you with that symptom. Okay, and it's often seen in the OPDs. The patient basically comes to you and eventually says you that there is a sudden onset discomfort or there is a pain in the perianal region, and following that there is a release of the pus. Okay, and sometimes this pus discharge may be associated with the blood as well, and following the release of this pus there is a temporary relief that has been typical statement given by the patient. Okay, so this is going to be the another important clinical features apart from the previous history of anorectal sepsis. Now let's try to understand the basic anatomy. So we have the dentate line that has been situated between the rectum and the anal canal. Okay, and this anal canal is basically guarded or surrounded by two sphincter is there. So one is internal sphincter and another is the external sphincter. So eventually often we see that like the patient basically undergoes some operative surgery for this fistula, and following that there is a development of the incontinence. Now this incontinence following the surgery basically develops due to the injury or due to the effect of the external anal sphincter in that case. So how much amount of the external anal sphincter basically damage, that is going to decide the degree of the incontinence in that patient. Okay. Now let's try to understand your intersphincteric fistula first. So it has been the most common type of the fistula. It has been seen around 70% cases. Now what exactly happened is that so it basically develops from the dentate line. So at the dentate line there is a glandular origin is there. Now from this dentate line the internal opening starts and the tract basically travels through the internal sphincter, but it does not traverse through the external sphincter. And instead of that, the tract basically lies in between the internal sphincter and the external sphincter, or the plane in between that two sphincter, and that basically opens into the perianal skin. So that's why this intersphincteric fistula, the external opening or external skin opening of that tract is basically located very close to anal verge in that case. Okay, very close to anal verge. So they basically lying between internal and external sphincter between, and external opening is basically located near the anal verge in that case. Now, they are the less common, less complex kind of fistula that we often see. So, as a result of that, a simple fistulotomy would be enough to treat such patient, and the patient even doesn't even develop incontinence. So, the risk of incontinence is pretty much low, and it's a safer option for the patient, right? So you can easily able to see that in this image as well. So this is the internal opening and this is the external opening. Now the tract basically travels through the internal sphincter, and following that it basically passes in between the plane of both sphincter and opens in the perianal skin. So as a result of that, the distance from the anal verge is basic and your external opening is pretty much low in that case. Okay. Now let's try to understand regarding the transsphincteric fistula. So regarding the transsphincteric fistula, what exactly happens? The internal opening remains at the same area, like near the dentate line mostly. And now the after the internal opening, the tract basically traverses both internal and external sphincter. Okay. And then basically opens into the perianal skin. So as a result of that, it basically very much challenging to manage in such patient. So these are the complex fistula, and this basically requires some complex or staged approach to treat such patient. Okay, so why this staged approach? Just to migrate that tract. So following that, we can do delayed fistulotomy without interfering the without interfering the continence mechanism in such cases. Okay, hopefully you guys are able to understand. Now, as I have already mentioned, like the degree of the external sphincter injury that basically develops the patient, how much degree of the incontinence the patient will develop. So that's the point. That's the main idea of the staged repair. Okay. Now, our next classification is the suprasphincteric fistula. So, what exactly happens? The from the internal opening is the same at the level of the dentate line, and it basically traverses through the internal sphincter, and then it basically goes up between the plane of internal and external sphincter. You can see in this image, right? And following that, it basically crosses above the external sphincter and open into the perianal skin, right? So this is the another complex kind of fistula, which is the suprasphincteric, and it basically involves, number one is the internal sphincter and number two is the puborectalis muscle. So this muscle is basically is known as the puborectalis muscle, but not the external sphincter per se. So what we advise to the patient is that, so first the Satan is supposed to be applied, and following that we go for the fistulotomy. Okay. Then there is a extrasphincteric. You can easily see that. So this, in case of extrasphincteric, the connection is somewhere with a rectum. Okay, it's not properly with the anal canal. The internal sphincter, internal opening is basically situated much higher than that of the anal canal. So it's a basically developed as a complicated procedure. So it's basically the complication of some perianal or rectal operation in that case, and as a result of that, this extrasphincteric fistula basically develops. So the connection between the rectum and the perineum. Okay, so lateral extension may go through the external and internal sphincter as well in some cases, and it's a pretty much challenging to treat. Now let's come back to the question here. So in this question they have already marks with some arrow, right? So this one is the marking, and they have been shown that the tract is something like that. Okay, the tract is basically situated something like that. So we can easily able to understand this tract traversing internal sphincter clearly, but it basically traversing partially to the external sphincter. Now let's try to see the option. So it's obviously not a suprasphincteric one, not a extrasphincteric one. Now in the transsphincteric, they already added one option, that is the transsphincteric high, right? So in case of transsphincteric high, so this one is your transsphincteric high, not this one. So it's always safer to go for intersphincteric in that case, as your external anal sphincter is not completely traversed through the tract. So that's why I am going with this answer here. Okay, option A. That's why I'm going with this option. Okay, thank you.